Donc, Massimiliano Orri n'a de postdoctorant que le statut, que le nom. En fait, il a plutôt le profil d'un prof, je dirais, parfois milieu de carrière. Il a étudié en psychologie d'abord en Italie, à l'université de Padua. Ensuite, il a fait 2 maîtrises, une en psychologie clinique. Donc, c'est un psychologue clinicien qui pratique en outre avec des adultes qui ont des troubles émotifs. Et ensuite, il a fait un doctorat en psychologie et en sciences cognitives à Paris-Descartes, à l'université Paris-Descartes en France. Il fait un postdoctorat de type international avec un fellowship Marie Curie, donc un des fellowships postdoctorales les plus compétitifs, je dirais, au monde, puisque c'est européen et ça vise la mobilité internationale. Donc, il travaille beaucoup sur les troubles émotifs et le suicide. Alors, ce qui est une des choses qui est vraiment remarquable de Massimiliano Orri, c'est qu'il a eu son doctorat en 2015 et il a publié 51 articles. Donc, c'est beaucoup. Donc voilà, il est très, très fort en méthodologie et très productif. Alors, on est très content de l'avoir avec nous. Et sans plus attendre, Massi, je te laisse nous parler de ton programme de recherche.
Merci beaucoup, Sylvana. C'était une très gentille présentation. Je vais partager l'écran. Est-ce que c'est bon?
Oui.
Pas bien? OK, parfait. So, as Sylvana said, I'm gonna talk in English. And I'm very happy to present this project that focuses on the perinatal influences on suicidal risk across the lifespan. I choose to present this project because I think it's a good example of an interdisciplinary project. And as in the GRIP, we aim to work interdisciplinary. And so this project brings together expertise from psychology, psychiatry, perinatal medicine, and a lot of other disciplines. And I'm really happy to work with such interdisciplinary environment at the GRIP. Okay, so as not everybody here works on suicide prevention, I thought to start with a small introduction. And I will answer the question, why is it important to study suicide? According to the WHO, suicide is a leading cause of death worldwide. More people died by suicide each year than all other forms of violence, including wars and homicides. As you can see in this map, there is a huge variation in the rate of suicide across the world, with rates in Canada being about 10 for 100,000 people. As youth are healthy, they don't die because of heart disease or other problems, suicide ranks as second causes of death among those aged 15 to 29. And prevention, of course, is a big public health problem. Suicide, of course, is preventable, and preventive efforts in those last decades led to the decrease of rate in suicide in almost all countries in the world, with some exceptions, like, for example, the United States. Apart the prevention of suicide, it is important to also prevent other manifestations of suicidal behavior, like, for example, suicide attempts. Suicide attempt is at least 20 times more prevalent than suicide, and this is likely to be underestimated. In the Quebec Longitudinal Study of Child Development, we estimated that across adolescents between 13 and 20 years old, 4% of adolescents at each time point report attempting suicide in the last year. For a prevalence of suicide by age 20 or about 7 to 8%. Suicide attempt is the single most important predictor of suicide death. This shows that it is very important to prevent suicide attempt, to prevent death by suicide. But also it is important because suicide brings other consequences on the socioeconomic and health plan. And for example, these are data that we collected linking financial report, tax report, official tax report to the Quebec Longitudinal study of kindergarten children. And we studied the difference in growth in earning from age 21 to age 35 for adolescents who attempt suicide by age 21 compared with those who did not attempt suicide. And as you can see, the growth in earnings among those who attempt suicide is significantly lower than among those who attempt suicide. Of course, part of this gap is explained by underlying mental health conditions, for example, depression or other mental health problems. But still, when we account for those mental health problems, we still see a gap in adulthood for the annual earnings as reported by the tax returns. So adolescents who attempt suicide are also more likely to receiving welfare in adulthood, are less likely to report having a partner, and are less likely also to graduate from high school by age 20. So suicide attempt has also more negative effect than death by suicide, also affecting the later socioeconomic outcomes. But why is it important to study suicide from a developmental perspective? But there are different reasons. First, suicide emerges at the end of childhood and the beginning of adolescence. As you can see in the graph here, there is a very, very low prevalence of suicide attempts during early and middle childhood, but during adolescence, there is a spike in suicide ideation attempt. Also, the concept of death emerges gradually during development. And finally, during adolescence, there are a lot of biopsychosocial changes and cognitive changes that may influence the likelihood to attempt suicide. For example, biological changes include puberty. Psychological changes may include acquiring skill to regulate our own emotions, and the social skill includes being integrated in a group of peers with all the interpersonal problems or not that can occur in adolescence. What is also important is that suicide early childhood is a critical period for preventing mental health problems, but also for support and healthy development in general, and also to enhance human capital. I like a lot this figure because it really exemplified what I mean. Thanks to developmental plasticity in early life, intervention that intervention during early childhood have the potential to really change the trajectory of possible risk for diseases more than, for example, intervention later in life that can have a more limited impact in the long term on the general development. The importance of studying the early childhood and the early years of life is exemplified by the developmental origins of health and disease. This model emphasizes that poor developmental experience around birth before birth can increase the risk of non-communicable disease later in life. This theory sometimes talk about fetal programming, but in general emphasize the role of preconception and pregnancy as critical windows in the lifespan, with a potential to have an effect until adulthood. This theory was conceptualized around the 90s and with evidence showing, for example, an association between birth weight, which is a proxy for a reduced fetal growth, and the cardiovascular disease and diabetes later in life. Later, there come evidence that show association between perinatal adverse events and the mental health conditions, for example, psychosis, schizophrenia, and ADHD. What about the evidence supporting the developmental origins of suicide? To answer this question, we conducted a systematic review and meta-analysis. We searched in the literature for articles in population-based sample, the study association between all perinatal and prenatal factors, and suicide, suicide attempt, or suicidal ideation. As we show here, we identify 42 studies. We investigated a lot of risk factors, including some that index family of parental characteristics, other that measure socioeconomic position at birth, other poor fetal growth index, obstetric complication, and medical condition or other exposure during pregnancy. Briefly, to go through the result of the meta-analysis, we found an association between different indexes of family and parental characteristics with suicide attempts. With suicide attempt and suicide death. I am showing result for the outcomes died by suicide. Briefly, we saw that children born high in the birth order, born second, third, fourth, etc., compared with children born first, were more likely to die by suicide in adulthood. An association was also found for children from teenage mother and children born from families with single parents family, that most often was single mother families. Associations were also found between different indices of socioeconomic position. Low maternal education, low paternal education, and low socioeconomic status were all associated with an increased risk of death by suicide. We found also association between poor fetal growth and development and the risk of suicide. Children born with a low birth weight, or children that were small for their gestational age, which basically is birth weight but accounting for the weeks of gestation. Children that have these characteristics were more likely to die by suicide in adulthood. We did not find any association for prematurity per se. No association was found for other obstetric characteristics such as C-section or for other exposure, a condition during pregnancy, including exposure to smoking during pregnancy. But these would deserve an entire conference because it's a very complicated risk factor to understand. Without going into the detail, the analysis suggested that there was overall consistent results across different outcomes, suicide attempt and suicide ideation. But as you can see here, there are fewer studies that investigated those outcomes. Most of the studies were investigated suicide as an outcome. Overall, those evidence show that there may be an association between family and parental characteristics at birth, and also between fetal growth characteristic at birth and risk of suicide and suicide attempt. But no evidence support an association between exposure during pregnancy, for example, smoking or other type of exposure, and obstetric characteristics. So going forward, we decide to investigate further the role of birth weight. Birth weight, the association between birth weight and the risk of suicide was consistent across different outcomes. We found an association for suicide mortality, suicide attempt, and also suicidal ideation. But of course, low birth weight also co-occur with different other risk factors. As shown here, for example, across different years, children for disadvantaged families have a rate of low birth weight substantially higher than the rate of birth weight of low birth weight among children born from non-disadvantaged family. So to explore how those risk factors can co-occur, we to try to better understand at least their co-occurrence, we ask ourselves two questions. The first was, how do low birth weight and other perinatal factors cluster together? The second was, is there a specific role of birth weight on suicide risk that is independent from other co-occurrent and possible confounding risk factors? So to address the first questions, we use data from two longitudinal population-based cohort studies. The first is the Quebec longitudinal study of child development, that most of you know. Is a representative sample of infants born in Quebec in 1998 and 1999 that were followed up until more than 20 years. For this study, we used 77% of the initial sample, that is more than 1,600 participants. The second cohort we used is the Avon longitudinal study of parents and children. It is also a representative population-based cohort that includes more than 40,000 participants at the moment of the inclusion. They were born in 1990 in the UK and were followed up until at least age 21 for this study. And for the study, for the analysis we performed, we were able to use 5,250 participants that correspond to about 37% of the initial sample. So in both cohorts, suicide attempt was assessed. In the Quebec longitudinal study of child development, was assessed at age 13, 15, 17, and 20, with the question, in the past 12 years, have you seriously thought about suicide? And if yes, how many times did you attempt suicide? So we consider at least one time as a positive for suicide attempt. In ASPAC, the first question, the question were asked 16 and 21 years, and the question were, have you ever hurt yourself on purpose in any way? And if yes, on any occasion, have you ever seriously wanted to kill yourself? So despite the slight difference in the questions, we noticed a remarkable similarity in the rate of suicide attempt in the two cohorts. There were about 8% in both cohorts with the same distribution by sex. So in this study, not only we assessed low birth weight, we also assessed 31 other potential adversity factors that were all measured at birth or within the first 5 to 8 months of life. So those factors were, some were measured fetal growth, so low birth weight, but also short blood length, small head circumferences, prematurity, etc. Other risk factors concern pregnancy complications, like diabetes during pregnancy. Other were in the category delivery complication, for example, C-section, hypoxia, or being transferred in a specialized hospital at birth. Other factors concern socioeconomic characteristics, like low education of the parents, low socioeconomic status, and low age of the mother. 4 other factors measured exposure during pregnancy: exposure to smoking, alcohol, medication, and illicit drugs. And finally, there was some risk factor that measured psychopathology or parental mental health problems. We had depression, anxiety, and antisocial behavior of both parents. We used a person-centered technique called latent class analysis to derive profiles of children based on the way these exposure cluster together. So we identified 5% of children for which they were more likely to be exposed to adversity during pregnancy. So this is these are all the adversity, And this is the prevalence of each adversity. And you can see the adversity here in red that were in the fetal growth adversity category were more prevalent in this profile than in other profile. So we call this profile poor fetal growth. Another profile we identify, that we call delivery complication, were characterized by a high prevalence of birth and delivery adversity. Another profile, about 24% of individuals, were characterized by exposure to socioeconomic and psychosocial adversity. And finally, the rest of the sample, 50%, were we call low perinatal risk profile because they show the lowest rate of adversity in all the categories. So it was our reference category. What's interesting is that we were able to replicate those results using ASPAC. We identify the same profile with almost the same prevalence rate in the two cohorts. The difference was that in ASPAC we also identified a fifth profile that we call parental mental health, which is characterized by the fact that the parents show a high rate of anxiety and depression. Now, I think this theory is even more clear to show the difference between the prevalence of the characteristics across the cohort. So here in the y-axis there are all the risk factors we measure, and here in the x-axis there are the difference in the prevalence of each risk factors between children in the poor fetal growth profile compared to children in the no adversity profile. And we did the same for the other profiles, always compared to the no adversity profile. And as you can see here, for example, low birth weight were about 60% more prevalent in the poor fetal growth profile compared to the no adversity profile. Similarly here, for example, long hospitalization was about 60% more prevalent in the delivery complication profile compared to the adversity profile, and so on. So if you look at this figure, then overall we can see that the red risk factor are more prevalent here, the green here, the blue here, etc. Showing that these profiles are characterized mainly for exposure to one kind of adversity. So how this membership to this profile is associated to the risk of suicide attempt. So we used logistic regression to estimate this association in the Quebec Longitudinal study of child development in ASPAC, and also we combined the results using meta-analysis. What we show is that children in a poor fetal growth profile were more at risk to attempt suicide by adolescents in both cohort and the cohort combined. Also, an increased risk of suicide attempt was identified for children exposed to the socioeconomic adversity profile. And also, this is just in ASPAC, an increased risk of suicide attempt was identified for children exposed to the parental mental health problem profile. But no excess risk of suicide attempt was identified for children in the delivery complication profile. So we also wanted to try to explain those associations, and we consider some mediators, potential mediators. There were emotional, behavior, hyperactivity, impulsivity, pre-victimization, and cognitive problems during childhood. We wanted to divide this association that I just showed into a direct association and a direct mediated association to calculate, for example, how those mediators can explain those associations. So I summarize the results here. So we can, here in the y-axis is the proportion of the association that is mediated by a given mediator that are reported here in the y-axis, in the x-axis. We can, for example, just consider the red bar that summarizes a combination of all mediators. And as we can see, the mediators can explain up to 50% of the association between poor fetal growth profile and suicide attempt. The same was observed for children in the parental mental health profile. But however, for the children exposed to psychosocial adversity, those mediators were able to explain up to 40% of the association. So to summarize the results, we found that it is possible to identify different profiles of exposure to early life adversity. And it's interesting to note that these profiles are replicable in another cohort that is from a different country and different continent even. So those profiles were mainly characterized by high rate of a specific group of perinatal adversity. But we also have notable exceptions. For example, if we take the poor fetal growth profile, those children that were exposed to adversity during fetal growth were also exposed to adversity in some level. So to socioeconomic adversity, they were exposed, for example, to smoking during pregnancy, and they also had some complication during delivery. This suggests that it is pertinent to use a multidisciplinary approach, for example, to prevent outcomes in those children exposed to a lot of risk factors. Also, it's interesting that these findings suggest that the interpretation of the risk factors must be done in the context of other risk factors. If we, for example, consider long hospitalization, these risk factors was equally present among children in a poor fetal growth profile than in the children in the delivery complication profile. However, the children in the delivery complication profile were not at highest risk of attempting suicide, while the children in the poor fetal growth profile, they were at a higher risk of attempting suicide. So this same risk factor, the presence of the same risk factors should be interpreted in the context of other risk factors. And finally, also the study suggests there are different pathways to suicide attempt for children that are exposed to different type of adversity in pregnancy and around birth, which also can suggest something about prevention. If we prevent mental health problem in childhood among children exposed to socioeconomic adversity, we potentially be able to reduce substantially the risk of suicide attempt, while this may not be true for children exposed to other for example, the poor fetal growth adversities. So the second question that we want to address is whether birth weight has an independent role on a suicide attempt over and beyond those characteristics that co-occur during pregnancy and during the early childhood. In practice, we want to see if there is a potential causal role of birth weight on suicide attempt. We already showed these figures. We showed that there is an association that is consistent across the different suicide phenotypes. So low birth weight increase the risk of suicidal mortality, suicide attempt, and suicidal ideation. But all these associations are not adjusted. In some study where risk factors were taken into account, for example, they showed that when the model were adjusted for a risk factor like socioeconomic status, psychiatric comorbidity, maternal age, etc., the association between birth weight and suicide attempt is attenuated, but not completely explained. Also, if you look at the association by different categories of birth weight, we can see that there is a dose-response association between birth weight and the risk of suicide attempt. But of course, those risk factors that were accounting for risk factors that were measured in the cohort do not exclude the fact that other risk factors may be unmeasured. So how to verify or how to test a potential causal role of birth weight on suicide attempt, accounting for both measured and unmeasured confounding factors? To do so, we used an instrumental variable design. So in a nutshell, this design relies on the use of another variable, an instrumental variable, as a proxy of the main variables of interest, of the main exposure of interest. The interest of using another variable as a proxy of the variable of interest rely on the fact that these variables must be independent from both measured and unmeasured risk factors that can confound the association between birth weight and suicide attempt. So the assumption of the characteristic of this instrumental variable are, first, there must be a strong association between this new instrument and the birth weight, so they can be used as a proxy. Second, there must be no association between confounding factors and the instrument. Otherwise, we just simply have another variable that is confounded. Third, the variables must be related to suicide attempt uniquely through birth weight. So there are not other pathways through which the variables influence birth weight. So the question is, what is a good instrument in this case? Finding a good instrument is maybe the most difficult step in this design. It turns out that genetic variants can be used as an instrument, as instrumental variables. And there are also good instrumental variables because genetic variants are, for example, not influenced by confounding factors. Socioeconomic factors cannot, for example, change our genome, or exposure to smoking cannot change our genome. So these confounding factors, both measured and unmeasured, that affect the association between birth weight and suicide attempt can be excluded by using genetic variants as proxy, as instruments. This design is called Mendelian randomization. And we try to apply this design to study the association, the potential causal association between birth weight and suicide attempt. So what is needed for this design is first to estimate the association between genetic variants and birth weight. This can be done by relying on a genome-wide association studies that found that some variants in the genome, some SNPs, are strongly associated with birth weight. So we have the first element of the puzzle. Then those same variants that are identified in another genome-wide association studies, the one was on the association, the genetic association underlying suicide attempt. And we have another piece of the puzzle. And having these two values to this association, we can easily calculate the third one, the one that we are interested in. So using this design, we found that there was a significant association between birth weight and suicide attempt. Specifically, for each standard deviation of decrease in birth weight, there was an increase in suicide attempt risk of about 39%. Interesting. We did not find an association between birth weight and depression, and between birth weight and schizophrenia when this same design was applied. Depression and schizophrenia are strong risk factors for suicide attempt, and sometimes in suicide research it is important to distinguish between factors that are specific to suicide and factors that are shared with other form of psychopathology strongly related with suicide. Always applying this design, we found a significant association between birth weight and ADHD, and between birth weight and intelligence. We can we could think can be involved in the pathways between birth weight and suicide attempt, because cognitive skills and ADHD usually comes before suicide attempt. So what do these results suggest? The results are consistent with a causal role of birth weight in the pathway to suicide attempt. Also, the fact that we found no association for depression and schizophrenia suggests that birth weight could be a specific risk factor for suicidal manifestation more than a general risk factor for other kinds of psychopathologies. And the association between birth weight and ADHD and cognition support what is known also about the pathway leading to suicide. For example, ADHD as a component on impulse control that we know is strongly related to, is a risk factor for suicidal behavior. Very briefly, if we want to hypothetically think about prevention, how those results can inform about a possible way to prevent suicide from early life. I know that prevention of suicide from early life is a very, seems very far, seems very hypothetical, but let's think hypothetically. Hypothetically, if we trust the results of our meta-analysis, we found, and also we trust the fact that birth weight is causally related to suicide attempt. We have an element to say that preventing acting on birth weight can also reduce the risk of suicidal manifestation. However, if we quantify the preventing effort that are required to prevent one suicide attempt, for example, we can see that it's not very cost effective. In epidemiology, you can estimate the number needed to treat that basically answer to the question how many children we should hypothetically treat if we had a solution for low birth weight to prevent one suicide attempt. And the answer is 2060. It, of course, is not a cost-effective intervention. However, if birth weight is causally related to suicide attempt, we can think that population-based universal approach that aims to shift the mean of distribution of birth weight in the population can have an effect on suicide and suicide attempt at the population level. This may be very important, for example, in countries, for example, when low birth weight is a problem is more a problem than in other countries. Another indication, always thinking about prevention, we can also see the results of the latent profile analysis as another way to prevent suicide potentially. So the children in the poor fetal growth profile are children that are more at risk for suicide. But if we calculate the number needed of treat in this case, we can see that we would need hypothetically to prevent the risk included in the poor fetal growth profile among 23 children to prevent one suicide attempt. So this is way more cost effective than looking just at the causal role or the role of one single risk factors. So these may suggest the targeted approach to children that present a co-occurrence of different risk factors, both pertaining to fetal growth, to socioeconomic adversity, and other risk factors, may be more effective to prevent negative outcomes among those children later in life. To conclude, I would like to briefly mention some future direction in this work. Currently, to go beyond those results, we're trying to understand whether the risk factor at birth, the early life risk factor, can help us to predict future suicide attempts. So go beyond just the association between two risk factors, but using machine learning algorithms to see, to quantify, and to see with which level of accuracy we can predict a future suicide attempt on the basis of those risk factors. And these are all the work of Marie Navarro. She's a PhD student that I'm lucky to co-supervise with Silvana. Secondly, we also are investigating more closely the role of exposure to smoking, not only during pregnancy, but also during childhood, to see if the cumulative effect of exposure to smoking during pregnancy or other moment of the development can be linked to increase the risk of suicide attempt. And lastly, I'm currently collaborating with a senior researcher from the Danish Research Institute for Suicide Prevention to work on their beautiful population register that counts more than 4 million individuals follow up from birth to midlife, in which we will have access to data about suicide mortality, suicide attempt, also data on the parents of the children, to test, for example, if pre-existing vulnerability in the parents can interact with adversity during birth to predict risk of suicide. We will also have data on their siblings to run some sibling comparison model, so to adjust for potential genetic confounding factors. And given the size of the sample, we will be able to look at specific risk factors and specific adversity in pregnancy. For example, being exposed to infections during pregnancy. But to conclude, suicide is a very, very complex phenomenon. And these figures just exemplify how complex it is to predict suicide. There are a lot of factors. There are distal, there are developmental, there are proximal, that in some way contribute to increase the risk of suicide during the lifetime. Being interested to these very early perinatal risk factors is maybe a part of the puzzle, and there is enough evidence to integrate the role of these early life risk factors in the model that currently try to understand how the risk of suicide develop in the lifetime. But what is most important to me is that those studies emphasize the role of conception and pregnancy, a crucial period for mental health prevention, especially from a public health perspective. I come back with this figure acting early in life in a moment where developmental plasticity is at the top, can really increase the chance of individuals to be more resilient to mental health problems and to develop in general a good mental health in life. So many thanks to all people involved in this project, from my supervisor to collaborators, to students, and not all are listed here, but thank you very much for all the collaboration, and of course, thank you for your attention.
Merci beaucoup, Massi. Merci pour cette super présentation. Oui, regarde, tu as des applaudissements. C'est très, très, très intéressant. Tu as super bien ficelé la problématique puis tes résultats. Tu sais, ta présentation de la randomisation mendélienne est la meilleure que j'ai entendue. J'en ai entendu beaucoup. C'est vraiment... on a l'impression qu'on a bien compris. Est-ce que Patricia Conrad est là? Elle a été invitée pour discuter la présentation de Massi, mais je ne la vois pas dans la liste. Donc, si Patricia n'est pas là, on va tout de suite ouvrir les questions à tout le monde. Je vous invite à poser vos questions. Vous ouvrez votre caméra, vous posez votre question. Si vous êtes vraiment très timide, vous pouvez les mettre dans le chat, puis moi, je peux les poser. Alors, je vous écoute.
J'ai une question, oui.
Oui, Nathalie.
Alors, merci, bravo, c'est excellent. Well done.
Thanks.
You know I love your work anyway, and I loved your presentation as well. Fascinating. Random question, just curious to see if you were like played around with data and you look at birth weight, you know, as a continuous variable. And I was wondering if you looked at it in different ways and whether maybe there's a nonlinear effect somewhere, or is there a kind of a threshold? Would you ever like find that, is there a certain, you know, limit, like if, you know, that could be clinically important in terms of like how low of a birth weight has like increased the risk? Do you have any idea about that?
Thanks, Natalie. Very good question. Well, if you refer to the Mendelian randomization analysis, these unfortunately we are very limited because we have a GWAS of birth weight, but we do not have a GWAS of low birth weight. So those we don't have the right instrument to look at low birth weight, or even to look at different thresholds. But what I understood from the literature is that the risk is really continuous, is a dose response effect, and yes, it's generally linear, but sometimes some studies reported an increased risk of suicide when the birth weight become too high. So it's kind of a U-shaped relationship.
Fascinating. Thank you.
Thank you.
Excuse-moi, Michel, j'avais mon micro éteint. C'est à toi.
OK, merci. Alors, bravo, merci. C'est une excellente présentation. Tout ça, c'est très fascinant de voir le caractère intégré de ta recherche et tout ça. Donc, bravo. J'ai été aussi fortement impressionné par ta présentation, notamment sur les aspects génétiques et la randomisation mendélienne. Effectivement, c'était une belle façon de présenter, très bien vulgarisé. Je suis curieux et je suis évidemment très intéressé par cet aspect-là. J'ai une question, peut-être un commentaire. La question, c'est c'est un score polygénique que tu as utilisé pour la randomisation? C'est un cumul de facteurs de risque?
C'était, je pense, 46 SNP qui ont été méta-analysés après. OK.
Une des limites d'une approche semblable, c'est que ça sous-estime très fortement la variance génétique qui est probablement associée à l'ensemble des phénotypes que tu étudies. Alors, c'est sûr que idéalement, ça serait de pouvoir, à un moment donné, compter sur un score polygénique qui explique une part beaucoup plus substantielle. On sait que c'est la plupart des phénotypes qui nous intéressent ici, notamment le suicide, probablement fortement polygénique, influencé par différents facteurs génétiques qui, cumulés, nous permettent peut-être d'arriver à une certaine explication de variance totale. Mais c'est sûr qu'avec quelques SNP, c'est sûr je ne suis pas certain qu'on est à expliquer une part importante de la variance. Donc, on sous-estime possiblement la variance totale. Je ne sais pas si tu as un commentaire à faire. Puis j'ai un autre commentaire par-dessus.
OK. Bah, merci Michel, merci beaucoup. C'est un très bon commentaire. Mais si j'ai bien compris l'approche de la randomisation mendélienne, en fait, ça ne devrait pas avoir tant d'influence que ça. Parce qu'en fait, on ne cherche pas d'estimer l'association entre les facteurs génétiques, les SNPs et le poids de naissance. Ça, on utilise ça juste comme un passage. L'important, c'est juste d'avoir assez de puissance pour pouvoir montrer qu'il y a une association entre les gènes, disons, et les SNPs et les pas de naissance. Après, l'association qu'on estime, c'est vraiment l'association comme si on avait utilisé juste une déviation standard de pas de naissance. Ça, c'est juste les calculs mathématiques.
Probablement qu'il faudra que je relise là-dessus parce que mon intuition, c'est que si tu as une sous-estimation de la variance génétique ou si c'est clique très peu, c'est sûr que tu peux observer une association spécifique, mais pas sur les autres aspects. Tu sais, on est vraiment dans une zone où il peut y avoir plus d'erreurs de mesure liées au fait qu'on sous-estime la variance génétique globale.
Okay.
Le commentaire que j'ajouterais, c'est pourquoi ne pas utiliser un modèle familial? Parce que le test de plus en plus rigoureux de ces aspects-là, c'est de s'intéresser à la variance intrafamiliale qui permet de contrôler pour un certain nombre de choses. Et particulièrement, c'est un design qui, par exemple, met l'accent sur les jumeaux monozygotes. Tu es dans un contexte où tu peux vraiment contrôler pour l'ensemble des facteurs génétiques pour vérifier si les associations que tu observes, les prédictions que tu observes sont maintenues. Alors, si jamais tu veux qu'on en parle, on pourrait certainement examiner la situation. Je pense qu'on a un design avec les jumeaux et que ce genre de modèle-là.
Ah, tout à fait, tout à fait. Je suis totalement d'accord. Alors ici, toutes les approches ont bien sûr des limites. Donc la chose la meilleure, c'est juste d'utiliser différentes approches avec toutes les limites et trianguler un peu les résultats. Si on trouve qu'on a toujours le même résultat, même utilisant différentes approches, ben, là on est sûr que peut-être il y a quelque chose. Oui, on avait brièvement parlé de ça, je me souviens très brièvement. Et c'est une chose que je cherche à faire, c'est en fait de contacter différents PI, différents cohortes de jumeaux pour pouvoir les demander de donner, faire un papier comme un consortium, pour avoir plusieurs cohortes qui estiment ça.
Parce qu'en bout de piste, la collaboration qu'on a eue montre aussi que le risque de suicide présente une irritabilité au-delà de 50%. Oui. Alors, c'est sûr que les facteurs génétiques sont importants et donc peuvent en partie expliquer ce qu'on présume être une médiation environnementale de l'impact, par exemple, des facteurs périnataux aussi.
Oui, tout à fait. Je suis très partant pour en parler à nouveau.
Merci, Michel. Est-ce qu'il y a d'autres questions pour Massimiliano?
Oui, il y a...
Gina.
Oui, merci infiniment pour cette présentation tellement stimulante et pour la qualité de l'intégration que vous faites de l'ensemble de votre travail. Là, c'est vraiment extrêmement intéressant de vous entendre. On aurait envie de vous amener avec nous puis de vous faire présenter à nos étudiants dans nos cours, etc. Ma question, c'est la suivante. Est-ce que ça ne semble pas pointer vers tout ça, l'importance du tabagisme durant la grossesse comme étant probablement une intervention de santé publique cruciale pour diminuer le risque autant de naissance de petits pois que de risques suicidaires qui peuvent en découler?
Okay. Merci beaucoup d'abord. Oui, c'est une question très intéressante parce que on sait bien que le risque de tabagisme est associé à un poids de naissance moins élevé. Mais apparemment, c'est assez complexe en fait, faire la différence entre ce qui est le risque dû à la grossesse, au fait de fumer pendant la grossesse, versus des facteurs génétiques qui sont très importants parce que, par exemple, les mères qui fument pendant la grossesse aussi ont un profil génétique différent, ont beaucoup plus d'autres problématiques psychosociales. Et nous cherchons en ce moment à travailler sur ça avec les données de l'EDEC. Nous avons estimé des trajectoires de tabagisme pendant la grossesse et aussi pendant l'enfance jusqu'à l'adolescence pour pouvoir voir si une exposition à un moment donné de la grossesse ou versus une exposition cumulée pendant grossesse et enfance peuvent être différemment liées à un risque de tentative de suicide, tout en utilisant des modèles avec un score de propension pour prendre en compte les différences entre les mères. Et ce qui semble suggérer cette étude, c'est qu'en fait, plutôt qu'une prévention du tabagisme au moment de la grossesse, il faudrait faire une prévention qui aussi va au-delà, parce que c'est l'accumulation de l'exposition à la cigarette pendant la grossesse et aussi d'autres périodes de la vie qui est vraiment liée à la tentative de suicide de façon peut-être plutôt causale.
Super. Est-ce qu'on a le temps pour une dernière question? Est-ce qu'il y a quelqu'un qui veut poser une dernière question? Ben alors, s'il n'y a personne, moi, je brûle de te poser une question. C'est une question assez classique, mais je voudrais savoir quand même ce que tu en penses, là. Si on te donnait beaucoup d'argent, là, voici, je sais pas, là, 20 millions, réglez-nous la question du suicide. Qu'est-ce que tu mettrais? Qu'est-ce que tu ferais? En termes de recherche, en termes d'intervention, qu'est-ce que tu...
C'est une très bonne question. Malheureusement, régler le problème du suicide, c'est d'abord comprendre pourquoi les personnes deviennent suicidaires. Ce qui est, à l'heure actuelle, c'est pas clair, pas du tout clair. Si on regarde les derniers 50 ans de recherche, on n'a pas identifié de facteurs spécifiques qui nous disent, par exemple, si vous sera prédit le risque de suicide. On trouve beaucoup de facteurs qui sont associés, mais quand on regarde est-ce que ça prédit, ça, on est vraiment encore au début de notre chemin de comprendre pourquoi. Donc, maintenant, sincèrement, la chose la meilleure pour prévenir le suicide, c'est agir sur les moyens. Par exemple, ne pas avoir des armes à feu, avoir fermé dans un coffre, etc. Ça, c'est les stratégies qui... Ça semble très basique, mais c'est la chose qui fonctionne le mieux pour prévenir les suicides. Mais sinon, si je devais investir sur d'autres choses, peut-être qu'un investissement sur aider les gens à prendre la régulation émotionnelle, c'est quelque chose que je pense que c'est très prometteur. Parce que parfois les suicides, tenter de suicide, c'est le résultat, c'est une tentative de régler des émotions qui sont dépendantes par ailleurs et que voilà, on n'a pas vraiment de moyens des stratégies pour les réguler. Donc donner aux personnes, aux jeunes des stratégies pour réguler les émotions, ça sera un investissement que je pense que est fructueux pour la prévention du suicide.
Excellent. Merci, Massi. Super.
Voilà.
Massi, merci beaucoup. Ta présentation était à la hauteur de tes travaux, de très, très haute qualité. Merci d'avoir accepté notre invitation. Merci à tous d'avoir été là. Et puis, on se retrouve au mois de novembre, le 3e vendredi de novembre, je crois, pour notre prochaine présentation, notre prochaine conférence du CRIP. Merci à tous. Au revoir.
Merci à tous.